All right. Jess Ellis, thanks for joining us today. Where are you coming from?
Right now, I am not in our beautiful state of Arizona. I am in Sacramento right now.
What are you doing in Sacramento?
Just enjoying a little bit of sunshine, getting out, avoiding the 107-degree heat that you're feeling right now.
Yeah, it's plus it's humid now. Like we're in the middle of monsoon season, so it's like 105 plus 60% humidity. So, but
Haboob.
the rest of the country
Yeah,
is kind of like that too. I was in Chicago a couple weeks ago. It's rough.
it is. But yeah, it's pretty good right now. It's 98. Yeah, it's been good. So I'll be back in Phoenix in 2 days.
Yeah. So, for those of you who don't know Jess, I think I could give you a little bit of an intro, Jess, but do you want to maybe introduce yourself and maybe kind of after that fold into what you're doing these days?
Yeah. So my name's Jess Ellis, originally from North Dakota, went to school at University of North Dakota. Um, Decided I couldn't deal with cold anymore, so I decided to head south with my wife. We relocated to Phoenix, worked at a corporate PT for a while called Physiotherapy Associates. After 2.5 years and 30 patients per day with paper charts, I was like, I can't do this. This is not what I signed up for. And I connected with somebody that you know very well, Tim Fearon, who basically saved my career. Instead of going back to med school, I just shadowed him and said, that's a completely different way of practice that I now can achieve. You've exposed me to something different. So switched practices, went to a private practice, cut my patient volume in half. Hung out with Tim every opportunity I could, went through the fellowship through Evidence in Motion, just like you did, and then really refined my skill. And then after 6 years, I was really trying to get into a company called EXOS, which is a human performance company that's headquartered in Phoenix. Interviewed for 10 different jobs, didn't get past the first round. Finally, on the 11th try, they gave me this substitute, hey, go to China and work for 6 weeks. I quit my job on the spot to do it. Didn't have anything on the way back, but it gave me access to EXOS. Spent it a year later. I was director of PT for the company. From there, that got me opportunities in pro sport. I got into the Portland Trailblazers as director of player health and performance, and then I followed that up with VP of health for the Knicks for the medical department. Now I'm back in Scottsdale. I got a 6 and 8-year-old son. I want them to know who their father is, and I've refined my practice to a cash base. I have a Con Ed company called Rehab Code that teaches basically mentorship and sports rehab. And I do some consultation. It's called Confirmed, which is a medical management company for professional athletes. So that's a very quick synopsis of the journey. But I will tell you, Seth, I went from seeing just a bunch of reps and being a shitty PT to then refinement and become the fellow, become the orthopedic manual therapist with test, retest, Maitland concepts, etc., to then go into a human performance company that looked at movement and everything else and integration with different disciplines, to then professional sports, where I dabbled in isokinetics and physics and a lot of the technology side. So I'm just somebody that's got a general span of many things.
Yeah, man. There's so many different like threads I could pull on there, but give me kind of a overview. Like what's a day in the life of Jess like these days?
Well, with a Con Ed company, you really have to, there's a lot of competition, and people want to know who they're learning from. So Rehab Code requires a lot of stuff I've never done before. I've been on the pro setting for a decade, to now having to look at, how do I write a newsletter? How do I create a hook for a reel that will catch your squirrel brain of attention span of 2 seconds. How do I catch it to own it? So that's where I'm at right now, is creating content, trying to provide value, and then again, consulting, working with individuals that have complicated cases, having the ability to look at technology and data, but have been in the trenches long enough to know the clinical side, and playing both worlds of the scientist and the artist that it's really hard to achieve.
Yeah, I mean, I guess one of the reasons I asked is it seems like you have a lot of different hats and things that you're doing during the day, but I think a lot of people maybe that are listening to this, then, you know, maybe newer grads or early on in their career are kind of like you, where you kind of get in that little wheel and you can't see maybe a future, kind of like what you've created that's for yourself, where you have all these little different things. There's some variety to your day and you have a lot of control over it. Was that something you did intentionally?
Dude, I have no clue. I was so much on the front end, just grinding and seeing patients to the point of burnout. So for me to step back and be 17 years in my career to say, all right, for $99, I'll give you the blueprint to get where I'm at. A lot of it was blood, sweat, tears, frustrations. I did a PhD during COVID and having 2 kids while managing an NBA team.
Yeah, so, forgot about the PhD.
Yeah. So that in itself, I just think, for one piece of advice is, sometimes we can write all the goals in the world, the what ifs, what could possibly be the best thing ever. But I guarantee you, 4 years into my career, the stuff that I achieved 10 years later, I would not even have fathomed to have written. So those goals are constantly evolving with opportunity. And you have to kill the opportunity at hand. That is the key. If you are not excelling in your current role, you're wasting your time. If you're in the clinic and you want to be the director, and let's say that director leaves in a week, your name better be on we don't need to put this on an external application to find who's the best candidate. This guy is prime, ready to go. Like, you have to work for your next position. I think that's important because there's a lot of victimhood in our profession. Poor me, I can't do this. I can't see this type of client. I wish I could get paid more. Like, all of that is just, you got to fix it, figure it out. Do the thing that will get you to the goal that you want. And I mentor a lot of people on the clinical side, and I mentor a lot of people on the professional side of just personal growth and finding their weaknesses. And Tim, again, he's a huge source for both of us, but I use the Enneagram every day with my clients, with my mentees. You have to figure out their source of weakness, where they create their barrier to protect. Once you know that, you know how everyone ticks.
Yeah, I mean, that kind of reminds me of the story I heard from John Childs about Josh Cleland, how he was bothering everyone to be involved in their research studies. And finally, he's like, man, I'll throw this guy a bone. And he just blew it out of the park. So they did it again. And then same thing. And he just kept doing it. And then now you see where, how successful Josh has been with his research.
Yeah.
So that's what you got to do. I think maybe this is an interesting thing that I've don't consider myself a sports physical therapist. I'm kind of maybe more of a straight orthopedic PT. And I look at like the lineage of the sports physical therapists, where they kind of, I think, came from their training was through physicians originally. And then you had this other kind of wing of physical therapy that was OMPT. So I'm interested in like you going through fellowship. Did you ever feel like a black sheep in the sports PT realm? I mean,
oh, dude, I was N of one. I think I might have been the first fellow. It was probably me and Matt Tuttle. We kind of entered the industry at the same time for the MBA. And I'm telling you, like, I learned so many hard lessons about how I practice, about, just throw out any Maitland concept you want: patient-centric approach, test, retest, asterisks, etc., to an individual I see every day. It can be Groundhog's Day, checking asterisks, and like the psychology of the redundancy. Like, you have to pull back that reasoning and keep it more internal. You can't create that perfect model that you see in a clinic where somebody pays you and they're maybe seeing you two times a week with a home program. Like, I remember giving athletes home programs when I'm seeing them the next day. Like, that was very weird to me. And pathoanatomics, labeling, big concern there. To now, I go, I don't think we need an MRI right now. The head trainer who'd been there for like 30 years, he pulled me aside. He goes, you get the MRI. But whatever your reasoning, I'm going to tell you it. Cover your ass. You do it now. And I'm like, okay, let's do it. So that completely changed, that structure aspect. And it really evolved the way I looked at things, because I do feel like, just like with all of our practice and how we think of things, heuristics are very tied into it. But we do talk about, let's not talk about pathoanatomics. Like, let's not talk about the tear, this, that, and the other. But that is one layer depth of that question. If you go 2, 3, 4 layers in to know what that structure does and how it functions and how it relates to functional movement, then you have a better understanding of what movements you will have to regress because of the structure. So when pathology is set in the joint, the rules have changed. And that's something we have to acknowledge. But I think instead of being so lazy to say, let's not label it because we don't know what it is, no, let's understand what that structure truly does. The hoop stress theory with menisci, what does that look like? Why, if they have a posterior horn tear, what movements will they not like? Deep knee flexion. Okay, let's minimize our lunge depth or our squat depth because of the structure. And I would say that that was a huge piece that I learned, and that's pathomechanics.
Yeah. And so it sounds like, I mean, do you think fellowship training, how do you think that maybe influenced how you look at patients?
I always tell people fellowship training with concurrently working with Tim and the curriculum and 20 other people showing video cases, seeing how bad you really are, like that, like the whole total package was the biggest and best investment I ever did for my career. And I'm very lucky that I chose to do it, or I would be in a completely different setting. So I think for me, it just, that depth of reasoning that you always have to use, that deductive model, trying to simplify complicated situations, all of that really was refined.
Yeah, it seems like the clinical reasoning piece.
Yeah.
I mean, I was on a panel once, and there were a lot of sports physical therapists kind of there. So there was George Davies, I think, was there, and Sue Falzone, and so all these sports PTs, and they do a little case, and this is like, again, I think of myself as a straight ortho PT. You'll see some local athletes and things like that, but they're talking about a high school athlete who dislocated his shoulder, and there are actually physicians, sports orthopedists in the crowd too, and they're talking about, like, how do you calculate the decision making as far as, do you do surgery? He's a high level athlete. He's got a scholarship on the line. It's his senior year. So there are all these other things around this individual that you don't see. Like, you have to consider this person's sports future and all these people around them. And then at each level, I'd imagine that just gets more and more intense. So what's it like treating a professional athlete and balancing all these, other factors? I mean, they're making tons of money for each game.
It's tough. It really is. I think the interesting thing about sport is we put this on a very nice golden pedestal of what teams have you worked for? Like, it must be great being on the sidelines or being on the court. It is great. Don't get me wrong. That is a perk of it. The other piece is you lose so much clinical reps. You lose so much clinical reasoning. Like, that is all sacrificed. If you are like a staff PT, you probably have the director of rehab and then director of health and performance over you. So you're not autonomous in your approach. You're having to go through two people to decide what type of rehab. And that's frustrating when you're good, when you really want to do the thing that you went to school for. So just be careful. That can be a facade. That isn't the best thing for a lot of us. Okay. Then you put into effect the politics of sports and dealing with a player that has guaranteed money, matters on the sport, but NBA, guaranteed money. They can play or not play. They still get the same check. Now, that changes things. If somebody's on a 4-year deal and they have ankle soreness or ankle pain, they're not going to play. I mean, it matters on every individual athlete and how tough they are and how much they want to push it. On their final year, you see a lot of these guys play through more stuff because they want the next check. That's just human nature. I got to be on the court to play. If I am not on the court, somebody could take my role, and then I'm stuck with a bad deal for the next 4 years. So you see that, and that's always in the back of your mind. And then there's just challenges of the immediacy of results on stuff that requires biological healing. Having a front office member say, like, can he go tomorrow? It's like, no, he can't go tomorrow. Like, it's still an acute phase. Like, I'll talk to you in a week. So that's a challenge, is like every day feels like a week when they're out, and there's pressure every time. And then there's always the challenge of getting the prognosis right. Can this guy be back in a week, a month, whatever it is? And the issue that we have is it's not getting back to pain-free walking or a sit to stand or getting out of their car with less pain. It is playing 38 minutes, pivoting, the chaos of sport. How do you put a prognosis on that and be accurate? And that's the challenge and the beauty of return to play.
Yeah, and then, you mentioned staff PTs, but you've kind of had other roles in the organization. What are those like?
The further you're away from the table, the more politics you deal with, the more management, communication, dealing with coaches. You start doing the thing that you love to do. And when I entered the league, I was in the top role. So I kind of tell people, everybody has a different way to access sport. My grind was in the outside. I grinded for years, then got to a leadership role from the private sector, which then transferred to the NBA. So my grind was never in the NBA. So I was kind of the top guy initially. So I was already in more of that supervision management role, though I still worked with athletes. And I will probably double up on that, is if you are the top person, you still need to be on the ground. You still need to be working with the guys, because the further you're away and you're in your office and they don't have a relationship with you, when you need to connect and make decisions, they're just not going to trust you.
Yeah. And I remember this vividly. This is so long ago, but I remember being a student. I think it was my first year at CSM, and I see this course at CSM, and it's like something about getting into pro sports. And I'm like every other first year PT student, I want to be in pro sports. So it was like a packed room. Kevin Wilk, Todd Ellenbecker, there were like 3 or 4. I can't even remember the other ones, but they're all, maybe Mike Reinhold was there, I think. They're all talking about their experience. And the biggest takeaway for me was like, this lifestyle kind of sucks. Like, you're on all the time. You're working on weekends. You're going to be away from your family. So they were kind of like discouraging everyone in the crowd to get involved in this. What was your experience? Like, did you like it? Do you think that was right for you? I know you talked about how now that you have kids, you want to be around them more.
I mean, so there's a few things there. One is, I think when you enter the league, there's two types of people. There are ones that have an expiration date, and there are ones that are lifers. And there are some that are saying, I'm in it for this amount of time, and then I got to get out. And you already kind of have a sense of who those are. And then the lifers are just like, give me the cuffs. I'm here to the end. You're going to have to, bury me outside of the practice facility. Like, I'll give you the grave site. Like, this is where I'm going to end. So I think for you, like going into that situation, now the problem you have is the longer you're in the setting, you start to sway into becoming a lifer. Even when people initially think I'm only going to be here for 2 contracts and then I'm out, you start to lose your confidence of what can I do outside of sport. And when you're in it long enough, then that's all you know. Because it's daunting to be like, okay, what do I do now? Because there's a level of arrogance that I'm not going to go down the street and work at ATI. Like, I'm better than that now. I worked for whatever team. So your options start to dwindle, let alone your clinical practice kind of sucked for multiple years because you've only worked with 3 guys. Okay. So your confidence starts to figure out, like, what could I do? Well, I could maybe be a professor. Maybe I could do a concierge model like I'm doing. Maybe I can go into education. Maybe I can sell eSTEM units. Those are the decisions they have to make. And they kind of tap into their network to see what the next piece is. But I do think that, and then the other piece is you can get fired. And I've been fired. So that's another force is dynamics of, making the cut or not. And most of the time when that happens is not so much about how good you are. It's, did you play the political game correctly?
Yeah. Yeah. So, I mean, yeah, it seems like it's like you kind of alluded to. It'd be a great role for some individuals, and then maybe it'd be a challenging one for other PTs. I got to ask, I mean, what are your thoughts seeing the Knicks win the championship this year?
I love everyone that I worked for, especially the health and performance guys. I was just on the call with the head trainer, Anthony, and we just talked it up. I'm very happy for all of them. Clearly, it sucks. I gave the analogy of is like, you broke up with your girl and you don't really know anything about her, so now she's your ex. And then one day you like go on IG and you see her and you're like, oh shit,
she's Miss America.
she's way hot. She's got a nice job. She's got a better boyfriend than me. And you're just kind of like, good for her. No, but it would have been beautiful to have that ring. But I'm telling you, life's a journey, and I've gained more insight in 2 years after the Knicks than I've done in 20.
Yeah. Yeah. And so, I think this was maybe during, if I'm correct. I mean, you decided to do a PhD just on the side.
Yeah.
Tell me about that. Why did you decide to do that?
So I've always wanted to. That was one of the things I had written on my list of what I got to, accomplish from my bucket list. And while I was in the league, I was having issues with getting players to commit doing certain things like a force plate effort. I want to see how well you jump. And they were doing half-ass jumps. Well, that data doesn't work. And I had other guys refusing. I don't want to wear this technology, this wearable. I don't want you to have my data. So I'm starting to have these initial conversations, and then I'm looking and saying, like, nobody's talking about this. And there's nothing on research with this. So I decided, though I've never had read a qualitative study, maybe 1 or 2, I decided I'm going to do a qualitative study. I'm going to interview 15 NBA guys. I'm going to ask questions about what their beliefs are behind technology. Do they think the data is being used for or against them? What are ways that would be better strategies to roll out new technology that you get better buy-in? And it It was a really good study. It really explored the human psychology of, in essence, the employer and the employee and the ethical decisions behind that. And I always talk about it. If you had an employer and said, hey, Seth, you're your own boss. Let's say you give it to one of your employees. Hey, I'm going to give you this and we're going to track how you sleep because we want you to be efficient. We want you to be the best you can be as a PT. And the employee's going to grab the watch. You're going to track me outside of work. You're going to see how much I sleep. And then you're going to dictate my performance off that. And then in a month, let's say her numbers are low. She's not seeing as many clients. And you say, your score's down too with sleep. You're hitting only 68s. So can we get better at sleeping? And she's like, what? Why does that matter? And that kind of hit me right square between the eyes of like, I would never want that happen to me if my employer told me to do that. Why the hell do I think that a player would?
Yeah, and they're, sometimes you forget watching them. They're in their 20s. I'm sure they like to go out every once in a while, and you don't want someone getting on your case about that.
I don't think we instinctively put them as a lab rat, but we're so caught up in producing the best product, producing the best system, that they become the lab rat. Because you throw all these different things to make human performance better, but there's never one time that we ask the athlete to say, what do you think? You want to do this? Does this make sense? And it's a very one-sided process. And that's why you see all the empirical data on the accuracy, the reliability, the validity of all these devices. And there's this much research on player buy-in and figuring out how to get them to buy into using that.
Yeah. I mean, maybe that's a good segue to this, is that, as manual therapists, sometimes we don't want to do the MRIs or collect the data as much because we're afraid of the decisions that are going to come as a result of that. Where do you think that's beneficial? Where do you think maybe that is warranted a little bit? What are your perspectives?
I think it's just being more level-headed in your reasoning and knowing that we all have biases. We all have different ways that we look at the problem. And we have to look at the lens that we look at all of our problems. And then there might be one day where I'm going to change the lens and put this one on. Way different perspective, way different look. So I think that's important, is just knowing where our default is and being much more willing to go that next route. And, and I know is like, how many times do you see a client when results are kind of nil that we got to say, okay, we got to figure something out? It's either we got to go to an image, we maybe see the doc, or the hardest one is, I don't think I'm good enough. I have a colleague that is better than me in this specific area of treatment. I need you to go see them. And that right there is the opposite of shared decision model that we try to push. That's medical paternalism. Medical paternalism is biasing the way that you speak to a client to own power over them. And that seems like a very dramatic comment. But if you see an MRI and you tailor the language so that patient doesn't have the full idea of what's going on, because you don't want to set fear into their beliefs, that's not the shared decision model that we need to be striving for. We are going back to the old antiquated medical paternalism.
Yeah, I saw a commentary about this in a physical therapy journal and actually wrote a letter to the editor about it. I think you do see this bubble up where when it comes to diagnosis, so people want to say, maybe let's not tell them they have a hamstring tear. Let's say that they have a problem with the muscle, just an injury, or just water it down. Like if you know what it is, you should be able to tell them and then explain it and put it in its place, but don't hide things from them. I mean, that does get to the paternalism kind of side of things.
And I, I think that 90% of what we do in pain science is done very poorly. I think if you're going to have those discussions, you better have those very refined, have practiced it enough times, because the last thing that you want to do is give a really corny ass analogy about pain to a client who has pain. And then they're going to say, why are you treating me like I'm a third grader? Tell me what's going on. And I've seen it go more south than I've seen it go way worse than it actually should. And I don't know if it's a level of arrogance that we want to give this type of approach, or it's just not like stepping back and like, is this common sense? Like, would I want to know this as a patient, or does this just seem very off? And if you can answer that, then we got to step back and change.
Yeah, I think that part of what I think you do see those discussions shifting a little bit lately, thankfully, and maybe, yeah. So I think maybe how we do it, we got to take another look at. And to your point, it's like, the whole idea behind pain science was to talk to someone and get them to understand things in a different way. And if they don't understand it, it's not working. So there is some tailoring, I think, that needs to happen there.
Yeah.
Do you see, you talked about mentorship. Do you see kind of common things in the physical therapists that you mentor, maybe pitfalls that they're commonly falling into or barriers?
From a personal development, there's just a lot of people struggling with where they're going in their career. And I think there's a few different angles that you can start to tailor the way that you want to approach it. One is, I want to be a master at my skill. So mastery is their pursuit. And if I'm in the coal mine just working on clients, like, I'm happy. Okay. Then the second one is, I want to educate. I want to become a teacher. Okay. Now you're going to have to look at reasoning and how can you teach it from your perspective. Then there's another angle, which is, I want to be a director. I want to go into leadership. I want to kind of lead groups. Okay. Well, leadership specific training. Fourth is, I want to be my own person. I want to be my own boss. I want to be an entrepreneur. I want to be able to just run a business. All right. Easy. Entrepreneurship. Then it's, I don't like any of that, but I like research, and I want my name on journals, and I want to maybe be in a little bit of academia, maybe be in and out and build that. And then the last one is Jess Ellis. No, it's consultation. It's, looking at working with technology companies, looking at kind of that hybrid model of using some of these this integration of sports, technology, physical therapy, biomechanics, etc. There's a whole new world of that in AI. So I think those are your spectrums of decisions. And then whatever, I take that list and maybe cut it down to 2. And then that's where you start to put more effort into, hopefully in 2 years, you're going to be closer to that goal.
Yeah. That's, that sounds like, do you run into issues with, well, imagine this is part of it, where physical therapy, there's maybe not that much of a ladder, at least from the clinic. So people get to a certain point, and then is that kind of, for the most part, what you're seeing in your mentorship group?
Yeah, there's nowhere to go, or the opportunities aren't there. And I've kind of talked about this on social media and different podcasts, but like, sometimes we deal with professional FOMO. And I think there's usually a split in the road of like, okay, this is kind of complacency and I'm just good enough, or this treacherous angle, which is mastery. And I think a lot of them kind of get bored and say, like, that just seems like too much work. I'm going to go down this path in complacency, but they're still intellectually wanted to be challenged. So what you find is they start going into strength and conditioning stuff, or they start wanting to do, some nutrition or this. And you're like, it's great to have that comprehensive view, but look let's be good at the thing that you went to school for. And I think a lot of them cut it short, and then they try to expand, and then they're just not good at anything, because they should be refining and continuing to build their skill as a PT. And the problem is then they got to look at themselves in the mirror and say, am I better? And that's a really tough question that a lot of people can't say, because there's a lot of psychology behind that. Sunken cost fallacy. Did you do the right education? You put all this time and effort, then you find out that that reasoning model actually sucks. There's not many people that can say I wasted time and money because I got it wrong. They just go along with that pursuit. And then just being honest, like clinical honesty is probably really hard for a lot of us.
Right. Yeah. So how does somebody know? I think this is probably a tough question, but how does somebody know that they're good enough?
You got to find some asshole to tell you if you are or aren't. You got to find the master. You got to find the person that says you're not there yet. Or the number one thing I say is, if you're in clinical practice and you're not being challenged and being humbled by at least 1 to 2 clients per day, you're not looking to get better. You're not looking, like, they're going to check you, and you're the one that has to receive that feedback to say, you're right, I didn't show up, I did it wrong. But a lot of times we go, well, that client's a little off, or, oh, we got a hypervigilant one, or you put all the excuses in the world. When it comes down to it, did you produce the result that you needed to? Did you adapt to your client? Or are you making an excuse? That's, I think, between finding that higher level mentor or just seeking to be corrected based on your patient interaction, are the 2 ways that you find out.
Yeah, I totally agree. You see this all the time. Jess, do you have, we're wrapping it up here. Do you have any parting thoughts? I mean, anything for the new grad physical therapists or the PTs that are kind of looking at fellowship training, or maybe those that are getting to the end and wondering what to do?
I think the more that I kind of evolved as a practitioner, I've become less idealistic in my thinking and more pragmatic. And that really transitioned, Maitland and fellowship is very, very aligned with the philosophy of pragmatism. And who created that was William James. He's the kind of the champion of that philosophical approach. They have a lot of alignment. It's very adaptable. It's very much seeking out the feedback from a client. Less of you talking, more of you listening, finding ways that are going to just do the one thing, which is achieve the result. And then step back and say, we can sit and talk theory all we want, but what's going to happen in the end? Is it going to change or is it not? And I think we kind of hide within theory. We get into rhetorics, and there's a safetiness to it because you don't really have to show it. And a lot of smart people can do that, but not a lot of people can truly be the pragmatic one to get the results and not really care about what really happened. Like, it was there and now, and you made the change. And you know why it happened in some capacity. We really, truly don't know what was the true extent of why it changed. We have some theory and we kind of rely on that. But you at least have a reasoning of what you think happened, good or bad. And I think that's important, is just be very practical and live in that realm, and don't get caught up so much in the theory, and don't get caught up so much in the social media about how people can tout about how good they are. I mean, you got to seek the ones that actually are doing it if anybody's in Tucson, they should be knocking on your door to see what you're doing. And if it's not, that's a problem.
Yeah, I think that's good advice. Jess, where can people connect with you and kind of learn more about what you're teaching these days?
Easy as rehab code. I do mentorship, one-on-one group mentorship. I do a cohort called Mentorship to Mastery, which is a 6-week dive. It's two to 2.5 hour sessions. The beauty of the mentorship is that you bring the questions to me. So every cohort's different. Every session I have to prepare and use my experience, and it's not kind of a prefabricated PowerPoint that I use through each cohort, which makes me stay honest throughout this process. So Mentorship to Mastery, I have a knee course and a shoulder neck course that I call the Schneck. And yeah, that's probably the easiest way to hit me up.
Sounds good. Jess Ellis, thanks for joining us this morning.
Appreciate it, Seth.